right, so pre-hospital trauma, we talked about pre-hospital cardiac before. A few little things about this. Same issues really occur. The place where you really need intervention quickly would seem to me to be the places where they don't have pre-hospital teams, advanced care. So the first couple of questions, there's this notion of the golden hour in trauma. Does time matter? And there's this big argument about scoop and run versus stay and play, right? And scoop and run is supposed to be get them there quickly so that the real doctors, the surgeons, can do what they have to do. We just said before that most trauma doesn't actually go to a surgeon. I mean, they don't really do anything about it. Versus staying in the field, do you actually accomplish anything in the field? And again, I think it's not a one-size-fits-all question. There are places where the response time is going to be quick. Minutes probably don't matter. Places where the response time is going to be very, very prolonged, maybe interventions would matter, but that's where we don't have the people to do the intervention. So the first couple of papers are actually looked at in moderate-sized cities, Buffalo and Denver, time in the field versus outcome in trauma. And what did they find?
Less time in the field, better outcome.
No, they actually found no difference. They found no difference. Now, of course, this is not terribly meaningful because you stay in the field longer, probably if the patient's sicker. They didn't control for that, right? The one who's got not much of anything, you just put him in the rig and you come there. So I don't know what this really means, but I do think it's probably right, which is that when you're going to be in the hospital quick anyway, it probably doesn't matter all that much, particularly since the large majority of the patients don't end up getting any real intervention. Most trauma patients don't. So even the ones where they are, they get lost in the mix when you're averaging everything up together. But you should know there is no definitive evidence that staying versus running makes any difference. That in mind, why do we put lights and sirens and jump on helicopters? Well, on the one hand, it may not help, right? On the other hand, it might hurt. How could it hurt, lights and sirens? 12,000 traffic accidents, major traffic accidents a year related to lights and sirens. In Los Angeles, how much time does it save? So there's one article here, number 3, is a rural one. This is from Hennepin. The title is rural, so it's not in the city. They went out on runs, but they had nothing to do, so they sent a second ambulance out on the run at the same time on lights and siren runs. And then they had, when the ambulance left, lights and siren back to the hospital, they followed without lights and sirens. How much time did they save? How much longer did it take them to get back to the hospital? So in this case, it's a rural place. They said 31% less, 3 minutes less. 3 minutes less. In Milwaukee, they did the same thing at rush hour with something like 38 seconds less. It's nuts. How often does that matter? And you're going to crash. What about helicopters? Articles 5 through 9 or 10 are about helicopters. What do they find? 1/3 of the children who were put on a helicopter to go to the trauma center, you got to get a helicopter. It's so critical. 1/3 of the helicopter things, they sent them home from the ER. No difference in any outcome in 2 of these studies, 3 of these studies. No difference in any measurable outcome when they had a helicopter service. Now, number 10 is the one exception. This is from Australia. And in this rural place, the helicopter wasn't any good, but they put a doctor on it, and they actually got better things. This is a place where it's out in the country. It took hours. Getting a doctor out there they increased what they were able to do, and the outcomes were better in terms of mortality and time in the hospital. It makes sense that where you're going to be in a place where some of the patients are sick, would take a long time to get to medical care to get somebody out there. Probably wasn't the helicopter, it probably was the person. But in general, it's not, in most of the circumstances where we do it, it doesn't seem like it really is reasonable. And remember as well that helicopter crashes probably kill more people. Every year there's deaths from helicopters, from medical helicopters, probably kill more people than all the patients you might save. Not to mention, in this room, I'm sure there's some people who work in rural environments and do EMS, and I'm just going to sort of jump the gun because I asked this at most courses, and they always say to me, and you can comment whether you have a different experience, but I've heard over and over and over again is that it doesn't even save time. Because by the time you get the helicopter up and get them out there and come back, you end up, it's in very rare circumstances, does it actually save you any time? Any comments? Anybody do rural EMS?
I mean, not a lot of people who come by the wagon thing. There's so much overutilization. The only time we ever find it truly valuable is actually we're very mountainous. We have communities who are remote. They have one EMS unit, so it would take them 5 hours to get to the hospital. They had no service by those people.
Sure.
And that's really the only place where you can really see.
So I think being rational would make it work. Somebody else wanted to comment? I mean, there's going to be some place where it will be useful, but mostly it's crazy. Then what do we do in the field? So there are two things we do in the field for trauma patients. One is we start IVs, and the other is we do airways. Oh, three things. The third is C-spine immobilization. So the first few articles are about IVs. You know that many years ago the dogma was you got to give lots of fluid. And then now there's this very big thing that's been going on for about 10 years. No, too much fluid is bad. So which is the answer? So of course we don't know the answer. So the first thing is there isn't really evidence. So what was the notion that too much fluid is bad? So they took animals and they put a hole in their aorta. And then they gave them lots of fluid or little fluid, and they noticed that when you give them a lot of fluid, you bleed more. Well, that doesn't mean that's bad. The notion is you got to get enough blood pressure to go to your brain. That's really important. So you can't let them be in terrible shock all the time. That's why we give them fluid in the first place. But if you raise their blood pressure too much, you're going to increase the amount of pressure at the hole, and more will come out. Well, first of all, very few of the injuries we see are like that. They're usually leaks. If you tore a big hole in your aorta, it doesn't matter what you do. Okay? So the concept, though, is if you raise blood pressure too much, you're going to increase bleeding, and that's bad for you. That's not entirely clear to me that it would be bad for you. Maybe you would increase bleeding, but the question is, do you stay alive long enough to get to the OR and fix the bleeding? That's what you really need to do. But in any case, remember, again, very few of our patients ever even go to the OR, so it's irrelevant to them. But what about the one who's hypotensive in the field? How much should you raise their blood pressure? Well, there is one famous study from Texas, from Houston, by Bickel. Bickel? I think it's his name. I'm just blocking on the exact name now. But where they randomized patients, they had a randomized control trial to a lot of fluid versus a little fluid when they had gunshot wound to the chest. Remember, again, gunshot wound to the chest, not your typical case, but okay, gunshot wound to the chest. They randomized them, a lot of fluid, little fluid, and they showed that they did better in the little fluid group. Because you're not supposed to raise the blood pressure too high. That was the whole thing. You're not supposed to raise blood pressure too high, that's a problem. That study, which was done, I published in 1990, something like that, a long time ago, has never been repeated. And I don't believe it. And the reason I don't believe it is twofold. One is, if it really was such an important thing, and it really was true, there have to be 9 other people who have tried to do the study again, and nobody's published anything else about it. So that makes it a little hard to imagine. But the other and more important part of it is, if you actually look at the study itself, the no fluid group got about 800 cc's of fluid in the field, and the fluid group got about 1.5 liters in the field. There was essentially no difference. And even more important than that, they measured their blood pressure in the field, in the ambulance, at the ER arrival, by the time they went to the operating room, and their blood pressures in the two groups were identical at every single time. So if, in fact, giving lots of fluids, which they didn't do, was killing you by raising your blood pressure too much, they didn't test that, because they didn't raise their blood pressure any different in the two groups. That all being said, and the absence of any real information about it, you don't need a blood pressure of 150 to perfuse your brain. So it seems reasonable that you don't want a blood pressure of 50, but maybe you don't want to be too over-aggressive, and you should aim for enough. Enough means a blood pressure of 100. That's all you have. You don't have to resuscitate so much that they got a nice, robust blood pressure. You just got to get enough blood flow to their brain. So I think that's reasonable. But the dogma, do not restrict fluids when they're hypotensive because they're going to bleed too much, is just dogma. It's silly. So a couple articles here. What do these articles say? They all don't really say very much of anything. But there is a subset of this where they ask the question, what about if you get this call that the patient was hypotensive in the field? Should you worry about it? Now, I don't know where you guys work, but I work in a place where there's a very rigid system of who qualifies to go to a trauma center. And you get to, one of the things that goes to a trauma center is they were hypotensive in the field. That automatically makes it that they get to the trauma center. So we see lots of those patients. Some of them come in, they're dying. They're really sick. Okay. But some of them come in and they're normal. They're not hypotensive. Everything's normal about them, but they had one blood pressure in the field that was hypotensive. So I've gotten a little bit sort of, casual about this. They look great. They're fine. They're normal. But these studies say that actually just having a blood pressure, I always think the paramedics made up the blood pressure, was wrong. But it turns out that having a low blood pressure in the field does predict a greater chance that they're going to need to go to the OR, and even that they're going to have a worse outcome. How do these two things stack up against each other? Well, yes, it does predict this association. Remember we talked about associations? But even so, more than 2/3 of the people who had a low blood pressure in the field never have any intervention. And 95% of them have a perfectly great outcome. So most of the time, it's a red herring. It's not a big deal. But I think it's enough of a red flag as well that you should at least look carefully at the patient if there's a report of a low blood pressure in the field. Of course, you should look carefully at them anyway, right? But, so yeah, there's a slightly higher risk that they will have a bad outcome, that they really need something, even if it was a transient drop of blood pressure. Most of the time, they're fine. One other really interesting little side take on this that I have no independent ability to comment on, but if it's true, and it's a pretty good study, we should all know about, is number 16. They looked at people who were hypotension in the field and what actually happened to them. A lot of them had no problem, just field hypotension. But of the ones who had a problem, some of them it was because they had bleeding. No surprise there. But some of them it was because they had, or at least it was in association with head injury. And in the little kids, the ones who were less than 5 years of age, 60% of them, it was isolated head injury. Now, I'm not sure I understand that, but this was a pretty well done study, and that's what they say. And that's a pretty high number. So even if it wasn't 60%, it was only 30%, it does suggest that for some reason, really little kids respond to isolated head injury with at least transient drop in their blood pressure. So just keep that in mind. The next little topic is C-spine immobilization. Really quick one. Can they do it in the field? I spent about 15 years working on, is there a way we can decide which patients are low enough risk that we don't have to do an X-ray at all? And we came up with these criteria, and I'm pretty confident that they work. And when we do it in the emergency department, I probably clear, I'm sure, at least 2 out of 3 people who come in on a stretcher. I clinically clear them. We never do an X-ray. They have to be really low risk. If I'm not sure, I'll get the X-ray. It's no big deal. But a lot of patients, I'm pretty sure, and we clear them, and they're fine. The question is, could they just clear them in the field? So there's a whole bunch of articles here, and mostly, the most important ones are the 2 by Domeyer. They did some really good stuff, number 19 and 20, where they looked at, could their paramedics be trained to clear people in the field? And for the most part, the answer is yes. They do really, really, really well. Unfortunately, there's a couple of cases which they get wrong. And it's mostly the T-spine, but there's a rare case in the C-spine and a few in the L-spine. So you can use that information any way you want. The way I use it, we see paramedics come in with people who are, they're walking around the field, they tie them down. It's crazy. I don't think that's reasonable. On the other hand, I would much rather have a system where they play it safe. I don't need them to clear it in the field. The big thing is get them to us. We have a rule. Somebody comes in on a stretcher with a backboard. They have to be seen immediately. They're as high priority as anybody because it takes 1 minute to get them off that backboard. You leave them on the backboard, they're going to be on it for an hour, and then they're surely going to have neck pain and back pain. So I'm not a big fan of have the nurse do it at triage, have the paramedic do it. I'd rather bring them in. We can do it. It takes no time and effort, and then you can clear them. But it is true that for the most part, they do a fine job if they're well trained. But of course, it's probably going to be variable. How often do they see it? Where do they work? Et cetera, et cetera. It's not like this is rocket science that you can't teach a paramedic to do it. Of course you can. The next and last little topic, all the last articles from number 22 on are about airway. And the most important of this, even though this is in a chapter about trauma, is number 24, which is not about trauma at all. It's Marianne Gaucher's study in Los Angeles about teaching paramedics to do intubations, and was that good? So what's the answer? The answer is outcomes are every one of those studies says outcome is worse if you do intubate them in the field than if you bag them in the field. Every single one of the studies. Most of them are not good studies, or they have lots of problems with them. Marianne's study, I think, is a really good study, and it's the one that I always rely on. This is, in this study, they got 6 different federal grants, 115 IRB approvals to do this. They trained more than 3,000 paramedics at 56 agencies, had more than 600 6-hour courses that they taught the paramedics. Then the paramedics went out, and they were randomized to do a bag valve mask or an intubation when a patient met certain criteria. And by every possible measure, it was worse the intubation, including deaths. These were very sick patients, so a lot of people died in both groups, but it was 4% more in the group that got intubated. And it was a large study, so this is a robust number, 830 children. And the study has been criticized because, well, they didn't have hands-on practice in real people. Each individual paramedic only did an occasional one, so of course they couldn't be any good. They didn't get cadaver training. There were a whole bunch of criticisms. This is nuts. No paramedic is going to do it more than these people. This was in Los Angeles. They did this Herculean effort to get them trained and retrained, et cetera. And you know what? They didn't do it very often. That's a fact of life. They're not going to do it very often. And not surprisingly, they're doing it in a very tough environment. Why did they have worse outcomes? Is it because ET is worse than bag valve mask? No, it's because it's not important for those extra 10 minutes. It's rarely, rarely important. And because every once in a while, they got it in the wrong place. You get it in the wrong place, and that's just about the same as putting a gun to the head and shooting the kid. Right? You intubate the esophagus, and you paralyze them in order to intubate them, or whatever it is, and they're not breathing, they're dead. And every study of paramedic intubation shows as low as 10% and as high as over 25%, it's in the wrong place. And how many times have I had a patient come in? They usually are going to die anyway, but they come in, they're in cardiac arrest, they're being bagged, the bag is on the ET tube, and oops, it's in the stomach. And I hear over and over, we hit a bump on the way into the parking lot. It must have come out. I mean, I don't want to rag on paramedics. They do a great job and on many, many, many things. And I'm sure that their skills in intubation could be good if they got adequate training and experience, and they didn't have to do it in crazy environments. But the way they have to do it, they make a mistake. And if you're not going to get much benefit, anytime you kill somebody, that's a lot of harm. And it's really easy. Just get in the wrong place. It does poorly. In any case, this is not just my opinion. There is no study which says there's an advantage to intubating in the field. And all of the studies, including the one that's really, really good, say, no, it's harmful.
How do they know that the patients that they intubated weren't just sicker and needed intubation versus the judgment being that it was just,
it was randomized. It wasn't a choice of we looked back at the ones who got intubated versus the ones who didn't. It actually wasn't randomized. It was alternate days. On one day you could intubate them, one day you were not allowed to intubate them, you could just bag them. So yeah, you can't say for sure, but it's unlikely that it had anything to do with it. And it slows down. There are all those other things, but that's probably less important. The real problem is that you get it in the wrong place, that's bad. And it's not like, we get it in the wrong place, we have we're checking right then. We're going to take it out if it's in the wrong place. Once you get them on the road and you're riding and it's in the wrong place, that's a horror. They did not, and so that's a good point. There's other people who persist in saying we should do this, say, well, now we have a technology we can tell right away and we can get it out of the wrong place. But in the absence of any evidence that you need to do it, that it helps, I think it's silly.
My experience, I've found that a lot of paramedics and nurses do not know how to bag a patient correctly. Are there any studies on this?
No. It's a good point. It's a good point. You got to do that well. But it is true that in this study, the outcomes were better. And in all the studies, the outcomes are better. So yeah, it probably could be even better if just like us, if we don't get very well trained in how to bag patients either.
But in Gaucher's study, she trained them for both the bagging and for the intubation. Those courses included both sides of the thing in terms of ensuring that they were optimal.
But certainly that's something we should do, is we should be better at, all of us, including paramedics. And if we're going to rely on it, of course we should do a better job of that. And then we're going to have the same problems about they're not doing it enough, but probably they'll do that a little more.